Welcome to the Ripple of Change podcast, where we highlight, celebrate, and extol others in healthcare and beyond doing amazing things. Today's topic is illuminating healthcare quality. Wow, there's a lot to unpack in this type of conversation. I am joined by two incredible human beings, Taylor Davis and Linda Komisak. I think I got that correct. For once, I didn't screw up the introduction, from Care Luminate. And I just think this will be so, how do I say it? What's the word I'm looking for? Maybe not flight of ideas, but it's going to go all over the place. So buckle up, get ready. I'm going to pass it over to Taylor, who's going to start us off with a question.
All right. Well, it's great to be here. And Linda, if you are not in healthcare, a lot of people don't understand the journey that healthcare workers walk through. And it really is taking you to this place where you're starting Care Luminate. So walk us through, what is it like being a new nurse, right? You're in nursing school, you're wide-eyed, right? Everything is about helping the patient. And then all of a sudden you hit the hospital and you realize that this is a business. And walk me through some of those experiences that took you to the place where you said, oh my gosh, we have got to do something different here in healthcare.
Oh, wow. Great question. So remember, I started as a nurse back in the day when doctors were smoking at the nurses' station. And when the doctors walked into the nurses' station, the nurses got up so the doctors could sit down and write in their charts. So yeah, I've been a nurse a really long time. But, you know, even as a doe-eyed new nurse, and I started my nursing career on a med-surg floor. I had a tour through an ICU, I had a tour through the OR, and then I ended up in ER and trauma and never left once I got there. That was kind of where my lifeblood was. Gosh, the journey to get to Care Luminate has taken me through the business side of healthcare. So working with some of the big box EHR vendors. And during that time, I was working with hospitals and providers to really figure out their place in the value-based care world that was changing. So it started with meaningful use and getting technology implemented, getting clinical documentation implemented, and eventually being able to drop a really good hospital bill, which we'll get to later, I'm sure. But all of that, so starting in the hospital and seeing sometimes I don't even think I knew that was really what healthcare quality looked like as a young nurse. But going through that process of working in a number of different departments, going back to school for the business degree and working with some of the technology vendors brings me to a place now. And in all fairness, towards the end of my career, where it all kind of pulls together in looking at healthcare in a whole new way. So pause here. Am I answering your question, Taylor? Is this where you thought I was going to go?
I was thinking that you were going to go down the route of talking about like the physician with the bowel perforations.
Oh, yeah.
But
I'm getting there.
You're good.
Okay, I'm getting there. All right. So all of that brings me to where I am today. And I have some specific examples. So when I was working in the OR, the hospital had not yet set up LDRPs up on the labor and delivery units. So we were still doing C-sections in the OR. And we had a surgeon with a 30% valve perforation rate during C-sections, which is, it should be zero. His was high. And everybody knew it. All the nurses that worked with him in the OR knew it, and they were starting to set up cases to prep for a bowel perf every time he did a C-section. So I had a conversation with my nursing leadership one day, and I said, what can we do to help him? How can we help not perforate bowels during C-sections?
And imagine how serious, this is a serious complication.
As you can imagine, opening up somebody's bowel inside their belly is rife with opportunities for infection that can go undetected for a long time and eventually kill somebody. It can mean bowel revision surgeries, depending on how bad it is. So you could come home with a new baby and a colostomy bag in some cases.
Did that actually happen?
Yeah, that actually happened.
Oh, geez. Wow.
Yeah.
Oh, it makes me nauseous. It makes me nauseous just listening to this.
Right. So my nursing leadership says to me, he's a pretty busy doc. He's a pillar of this community, and he has a pretty high volume coming through for C-section. So his patients don't seem to mind. I'm like, do his patients know? Do his patients know they could, come into the hospital for a C-section and go home with a diversionary bowel device and a baby? There was not a lot of incentive for hospital leadership to do anything about this surgeon. He was allowed to practice like that. At the same hospital, we had an emergency physician who had a roster of patients that came in seeking pain medicine. And he was convinced that his job was just to write them prescriptions for more pain medicine. So they would come into the emergency department with vague complaints of headache or back pain, and they had tried everything. And these patients were so sophisticated, they would come in and say, the only thing you can give me is Dilaudid. So the patients were coming into the emergency department saying, I need Dilaudid for my headache, or I need Dilaudid.
Which is not Tylenol. Just for anybody who's non-clinical, this is not Tylenol, right? So
yes, that's a potent medication, to say the least.
A strong opioid, yes.
So when you have patients coming into a hospital asking for that, and you have a provider who's saying, it's not my job to judge their pain, it's my job to treat their pain. I think there's a conversation to be had about the best way to do that.
But Linda, as we talk about these things, I mean, you talk about no incentive for healthcare to get better, but hospitals have tons of measurements. And so walk us through, why are these measurements not fixing these types of problems, right? They're measured in tons of different ways.
Sure. So I think the measurements, and I don't want to diss on the measurements that are out there, because I think it's better than nothing, right?
Yeah, there's a good intention there for sure.
Absolutely. Yeah. So I think the measurements that were developed were really around tying the cost of healthcare for Medicare. Let's be honest, it was CMS developed these for Medicaid and Medicare, and I think it was really to help people understand the correlation between cost and quality. So if a hospital is measuring how many catheter-acquired urinary tract infections are happening, that's not a bad thing, right? And being able to tie cost to that is also not a bad thing. The problem with those quality measures is if I'm going into the hospital for a knee replacement, likely not going to have a catheter, likely don't care what the catheter-acquired urinary tract infection rate is. So I think the problem with the existing quality measures, and we have CLABSI, we have CAUTI, we have all the bundled joint replacement quality measures. They don't always apply to the condition that the patient's going into the hospital for. So I don't think it resonates with patients, even if they went out and looked at them, which I don't think patients do. But even if they went out and looked at them, I think they'd look at those quality measures and say, that has nothing to do with me. So quality measures
they're a bunch of numbers.
It's a bunch of numbers, but it does not tell the story of what it's like to be a patient naked under the sheet, or not even naked under the sheet, but in a hospital gown that you need a Philadelphia lawyer to get in and out of. And no offense to Philadelphia lawyers, but it's not easy to get in and out of the gown underneath a scratchy hospital sheet.
And so Linda, and actually I think this is even one for Todd to chime in on, and I've asked bunches of clinicians this, but I come into healthcare, I'm a statistician by background, And so I start finding that healthcare has all of these measurements that hospitals have, right? And I start thinking naively, I'm like, well, these are the best measurements to know where to go for care. But then as I watch physicians and nurses and even hospital administrators, when they go to figure out care, they don't go based off of the measurements. So I start asking people, I'm like, so why are you not going off the measurements? Like, why are you asking people where to go and who to see? And I have person after person tell me, well, we all know the measurements are bunk. And we all know that the measurements are manipulated, right? Yep. So walk me through as a clinician, some of the experiences that maybe you've had or that you've seen that makes you look at some of those measurements. And again, I agree with you. I don't think that they're bad, but they're so manipulated, and you see that as a clinician. And those are the stories that I hear, right?
They're not relevant either. They're not relevant to me unless I have that condition.
Well, and I think that's a big, Linda, I think you hit the nail on the head. Like the data in and of itself, whether it's manipulated or not, it's probably a different question. But the reality is when you're presented with the data, there's often a story associated with that. And just because you've got the data doesn't mean that that's what is required for the individual that is sitting in front of you at that moment.
Right.
And I actually have a really good example of this. You had me thinking about this when you were talking. When I first started practice, this was not when I first started practice. In my most recent employed job, if you will, it was about 2010. I had an older patient. He was in his 90s, and I was new to the practice, and he came in. Long of the short, he had pancreatic cancer, which was metastatic. And we had done the appropriate workup. We had done the CT. We had done the blood work, and he had come in to see me about a week later. And I presented him with the information. We talked about options, hematology referrals, oncology referrals, surgical referrals, all these kinds of things. And he, oh gosh, I got to be careful because I could possibly start crying here, which is not what I was anticipating with this discussion. But he said, he looked at me, and I had known this gentleman for all of a couple of weeks at this point. He looked at me and he said, "Doc, what would you do?" And I looked at him and I said, "I would spend time with my family." And in that moment, for that patient, that was the absolute right decision for him. Mm-hmm. Having someone in their mid-90s go through potentially a complicated surgery, chemotherapy, radiation, whatever the course may have been, sure, it might have extended his life by who knows what, maybe a matter of months. But what would the quality have been, right? Right. And is that a negative data point on somebody's data checklist? Well, yeah, probably so. Was that the right data point for that gentleman? I don't regret that decision at all.
Yeah.
There's so much to unpack there, right? You know?
Oh, yeah.
That's a great.
There's a lot of those stories. I'll never forget the 87-year-old that I had with advanced dementia that we did a quadruple bypass on because the family wasn't willing to say goodbye to an 87-year-old with 10-year history of advanced dementia. We did a quadruple bypass on that guy.
Wow.
That's horrible.
So they probably nailed every quality measure around all the quality things that you check for somebody that needs quadruple bypass surgery. But was it the right thing to do for that patient in that moment? The family said yes. But the surgeon was like, "Really? Do you really want me to do quadruple bypass?" There's a ton of stories like that.
Oh, for sure. And well,
Dr. Marty McCary's book, Unaccountable, tells a million of them, right?
Yeah. Well, at least there's I see a little bit of a bright spot in that story that the surgeon was like, I don't think this is the right thing to do necessarily. But
he did it.
I did it. Yeah, well, you can't. Oh boy, that's a whole nother can of worms we probably don't need to go down right now. I would like, actually, you know, I'd like to hear really, and I'm going to throw this question at the both of you. You know, Linda, we had a chance to talk about the work that you're doing now with Care Luminate, and I was fascinated by it. I would love for the two of you to explain to the audience like what you're doing and maybe your vision for the company and that work, because I just think it's amazing.
Taylor, how do you want to you want to
do it? I'll start and you finish. How about this? So
okay,
I'll just say this. Here's my journey, Todd. I'm walking, so I'm a numbers guy, I'm a statistician. I'm realizing that none of these clinicians, none of these executives actually trust their quality measurements. And then I'm working in and with hospitals, every hospital across the country. Our company, I was president of a company called Class Research. Our company worked with them. One time I walk into a hospital in the Southeast, and they said, we had a horrible meeting with their leadership team. It was completely dysfunctional. And as we walked out, one of the administrative assistants said to me,
Wait a minute, Taylor. Hold on a second. You're saying there's dysfunctional parts of healthcare right now?
You know, there may
I'm sorry, I couldn't resist.
No, I mean, just
keep going.
The degree to which the dysfunction that you see it is absolutely shocking. So the leadership team is walking out. It's a horrible meeting. It's an absolutely horrible meeting. And one of the administrative assistants said, that went pretty well. And I was like, that went pretty well? And she said last time they started throwing furniture at each other.
Wow. Wow.
Real story.
Oh my goodness. I've seen some intense meetings, but I've never seen, WWF type stuff.
Yeah, but what is the level of dysfunction? I'd be in hospitals and nurses and physicians would say to me, this is a horrible place to get care.
Wow.
We don't do a good job here. And so I knew that the people in healthcare were hurting because their organizations were dysfunctional, and they were even willing to speak out about it. I read Marty McCary's book, Unaccountable, where he talks about the best measurement of healthcare is just, do the people in healthcare, do they trust it? And I started thinking about when I take my car into the mechanic. It's the same type of thing. When they come back and tell me it's going to be a $2,000 repair, I don't know if they're just pulling my leg or if this is real. So what am I looking for? I'm looking for a mechanic that I have somebody on the inside, right? So if I can know somebody there, and then and what do you want to ask if you have somebody on the inside of your mechanic? You're like, hey, are they taking from me for all that I'm worth, or are they really giving me what I should be getting, right? Because I don't know. I'm stupid, right? I'm stupid about cars. I'm also fairly stupid about care, and I knew enough to know that clinicians and nurses would speak out if they were given anonymity to say whether their organization was taking advantage of people, cutting corners, or if they were giving great care. And I thought, well, let's group source this. And so I put a post out on LinkedIn and said, I was transitioning job. I put a post out on LinkedIn and I said, thinking about doing something like this. And at the end of the day, I think that there's actually easier ways to make money. So, and we'll talk through that a little bit, but I didn't even care if somebody took the idea and went and started a company. It was about the need for this to exist in the world. And Linda reached out to me and she said, Taylor, I am so excited about this. She connected. I still remember it was on a Tuesday. It was about a year ago, almost today.
It's about now.
A year ago on Monday. And she reached out to me and she said, Taylor, I'm so passionate about this. And by Friday we were on board, and we're still in that early phase where we're not paying, ourselves, and we're getting this up and going. Linda and I show up and we put in long days every day, and we are happy to do it because we think we're so passionate about getting this type of information out to patients, getting this information to fix healthcare. And I don't know, Linda, you can just talk about the premise of what we're doing a little bit more, but it's going and group sourcing, interviewing these frontline nurses to give us their feedback about the quality of care in their communities. And we've done it in 5 communities so far, and it has been absolutely fascinating what we've learned. And if we can put it in the notes, we'll put an example to our Kansas City study, which is our largest one. And you just got to go in and read it. You just have to go in and read the nurse comments to see what they're actually saying about their hospitals. And you'll see crazy comments like some of the ones that we're mentioning here. So,
yeah, I think the only thing I'd add to that is that plays out in real life, right? The surgeon that I mentioned earlier that had the 30% bowel perforation rate did not have nurses as his patients. They knew. Our hashtag is #nurses know, because nurses know. They know a surgeon spends 15 minutes at the bedside of patients in the hospital, and the nurses spend the other 23 hours and 45 minutes with those patients. And they know everything that's going on in the hospital. So we like to say we're democratizing for communities what healthcare workers have done for years, giving the insider story. There's a million ways to say it, but healthcare workers make referrals to each other all the time. I wouldn't go there. I wouldn't see her. I wouldn't see him. Have you checked out this person? I'm hearing good things about that. That's what healthcare workers do. They don't go to CMS and they don't go to Leapfrog. The other thing I want to mention about Leapfrog and CMS, and again, this isn't a criticism because they started the work, right? The reason I know that those don't make a difference to patients is because the A-grade hospitals are as full as the D-grade hospitals. And the 2-star hospitals are just as full as the 4-star hospitals. That's how I know that those quality measurements today don't make a difference for patients. But when nurses who live and work in your community are telling you the stories of what's happening for patients in a hospital, we think that is incredibly powerful. So let's leave CMS and Leapfrog doing what they're doing, and Care Luminate comes in underneath to tell the story of what those scores really mean. So check out our Kansas City report.
Yeah.
It is fascinating.
I was actually looking at it this morning. I was intrigued. I do think it is fascinating. And I also think it would be very interesting to talk through the process a little bit that you utilize for capturing that data. To me as a clinician who's been surveyed, let's not go down the rabbit hole of what I think of engagement surveys or what have you, perhaps. But the subjective comments that you utilize in talking with the nurses, I thought that was incredible, fantastic.
You've never seen anything like it, have you?
Pick a superlative adjective you want to use in there. Please walk us through that a little bit, if you would.
Do you want to go to?
I was just going to add, because as a physician and as a nurse, you've done a million of these types of surveys, but they all go into a black hole because they're done by the hospital and they never see the light of day, right?
Not only that, I'm sorry, go ahead, Taylor.
Yeah.
You got me so excited. I'm like sitting up in my chair.
Yeah.
I'm grabbing a piece of furniture ready to throw it into the wall. I'm just kidding. No,
accomplished. We've done our job.
there you go. No, I think the other part of it is, right, like, what's the narrative that's going to be spun around the data? Mm-hmm. How can you spit shine garbage, and present it back like, oh, everything's great, and it's like, only 5% of the clinicians filled out the survey. Mm-hmm. Not everything is great when the other 19 out of 20 are so frustrated. They're not even wanting to take the time to do the survey because they know it's not going to yield anything. And that is happening all over the place.
Yeah, Taylor and I have said to hospital leadership, 20 times now, look, if you made your AHRQ SOP survey public, there'd be no need for us to do this. Are you going to make your survey public? No. Oh, no. So a couple of things. First of all, the nurses self-select to talk to us. They actually schedule an appointment to get on the phone with us to talk for 20 minutes. So we're not just sending out a survey that they can fill out online. They're actually scheduling appointments to get on the phone with a nurse to have this conversation. That's differentiating in our data. So these nurses they're not just on their break time doing an online survey. They're scheduling an appointment with us. So that we think that's critical.
And when you look at that Kansas City report, right, they're 20-minute interviews. So that's 150 hours on the phone with nurses asking them about the quality of care in their hospitals, right? So this is deep. There's a lot of comments there, right? So.
Well, and to click in there for half a second, you also suggested that it's not just from one unit, that you'll specifically make sure that you have a broad representation of the institution that you're speaking, of the nurses you're speaking to, right?
Correct. That has been incredibly core foundational principle for us is, look, very rarely do labor and delivery nurses say we're crap. Labor and delivery nurses seem to be able to do whatever they need to do to make their units work really well. They often complain about staffing issues, but labor and delivery nurses seem to take a lot of pride in their work. And we very rarely hear, don't have a baby here. It does happen. OR nurses, so PACU, pre-surgery, PACU, and intra-op, they never complain about their jobs. That's a pretty happy group. And the procedural labs. So So endoscopy, nuclear medicine, those nurses are happy. We're happy to talk to those nurses and get the story of what's going on in those units, but they need to be a fraction of the total. So we're looking at that, and when we have X number of nurses from a particular unit, we will shut off doing interviews for that unit. The other thing I want to mention is we had a conversation with a nurse executive who told us that her nurses don't know anything about bedside quality. And as a nurse, not only was I deeply offended, I was mad at her. And my pushback to her was, gosh, if your bedside nurses don't know anything about quality, that's a you problem, because that's your job, is to make sure that your nurses understand what quality is. But her pushback to me was, well, I have a quality department that manages our hospital quality. And I'm thinking, spreadsheet data is not quality. So I think there is this protectionism that's happening at hospitals because they are not incented to do anything different than what they're doing today.
And Linda, on that protectionism, you're doing this with the hospitals, right? The hospitals are opening up the doors saying, yeah, come on in, talk to our nurses, right? I mean, that's how we're doing it, right? And I'm asking that. Right?
Yeah. So when Taylor and I went into each of these cities, he and I spent a considerable amount of time reaching out into the hospital, into marketing departments, the executive suite, the nursing suite, any way we could try to have a conversation with somebody in the hospital to let them know we were coming and doing this. And when we would have that conversation with an executive, they were like, no, we're not interested in participating. Don't come talk to our nurses. They're already over-surveyed. They were like, yeah, we're kind of not asking for permission. This is happening. We just want you to be aware that it's happening. And it was shocking to me, some of the responses that we got from executive leadership about talking to nurses. We had another executive tell us that he did one-on-one rounds on nursing units. And that was interesting to Taylor and I. We were like, oh, that sounds really great. Tell us more about that. Well, I go out and I talk to the nurses, and I bring their nurse manager with them to make sure that the nurse manager can provide the context. And I was like, so you're not doing one-on-one rounding, you're team rounding. And you're not having one-on-one conversations with the nurses. And he insisted that the conversations he was having with nurses, with their nurse manager present, was helping him get to the bottom of what was happening in some of the nursing units in his hospital. Fascinating.
And we heard the other side from the nurses. We spoke to 37.
Oh, I could imagine what the responses were.
And I just want to add, he is no longer employed by that institution.
Well,
the conversations went like this. The nurses would tell us, they'd say, I'm in a cardiac unit with people with open chest wounds, and that we're not open chest wounds. Sorry, clinicians, help me out here with the tubes. Chest tubes. Thank you. And with chest tubes, taking care of these patients, and I have 6 patients or 7 patients to one nurse. And so he comes by and tells me, well, that's not what we're doing. That's not what the numbers actually are. And the nurse is like, that's what I did last Tuesday. I was taking care of 7. And so then the nurse manager is telling him, well, that's not actually what the numbers are, because the charge nurse is there for you. So that brings down the numbers. So they're having this asinine conversation about what actually is happening. And the nurse is sitting there saying, no, I'm taking care of 7 people. I get 8 minutes per. And if one of them has an issue, I've got to work on them for 40 minutes. And I'm losing patients. Patients are dying. We've had nurses crying with us. And then we get on with administration, and administration in some of these bad hospitals will be telling us, no, you got it wrong. You don't understand the spreadsheet statistics of what's going on. And we're like, no, we heard it from the source. And anyway, that story, it just bothers me to my core. I don't sleep that night. It was so fun.
In the oh my goodness, these types of issues are all over the place, unfortunately, which is why, but that's why we're having these conversations, right? Because you know, the work that you're doing and having people with the courage to speak up and rip the Band-Aids off some of these existing wounds is how we're going to improve some of these things. And so, and actually, before we get to a Ripple Challenge question, there's one last question I really want you to both answer here, because typically we'll go for about 30 minutes, and I'm always watching the clock because I don't want to be behind for the next patient. No, I'm just kidding. So no, the question I wanted to ask was, in terms of this data, who do you see, or who is utilizing this or wants to utilize this data to facilitate the changes that are desperately needed?
Yeah, the people who pay for healthcare are the people who are really interested in this data. So employers, employees, people who are looking to pay for healthcare in new ways are really interested in this data and using this to be able to go to a hospital and say, gosh, you're doing really great. I'd love to contract my employees with you for cardiac services. Or, gosh, you kind of stink, and we're not going to send any of our employees to you until you fix some things. That's where we're having some really interesting conversations. Taylor, what would you add?
Yeah, and Todd, let me just say this. We could measure the whole United States with $15 million. Nobody's shown up and written us that check yet. So Linda and I have said, do we need to go find new money? The good news is that there's so much waste in healthcare. And so here's the way that we're going about it. And we need everybody who's listening to this podcast to help. These studies will not. Now, here's the good news is we're having daily 3 to 6 discussions with people saying, how can I help you get into my community? How can I help you do this? So it is going to happen, but I'm saying it won't happen without people doing that. If we get one of the 5 largest employers in any city to let some of our partners come in and save them about $1,000 an employee by cutting out some of the waste with bad hospital billing. So there's no cost to these employers. There's only savings. To a lot of these employers, the savings may be tens of millions of dollars. If you let us come in and do that, then we'll use part of our shared savings to do the study in your city, and we'll do it ongoing. So that's the way that we're structuring it, but we've got to get attention because there's a way to harness the volume of healthcare in these communities. Healthcare in any large community is in the billions of dollars. By cutting out a fraction of the waste in those communities, and there's ways to do it today that established brokers and employers are resistant to do. But if we can get some healthcare heroes, if we can get some people who really care about it, it's more time than we have to talk through the drama, the soap opera drama that we've experienced in working with groups to try to make this better. Let me give you one example though. We go to large insurance companies. They're called BUCAs a lot of times because it's Blue Cross, Blue Shield, United, Cigna, and Aetna. The big insurance companies. And we say, hey, here's information that could make a huge difference. And you know what happens is that they say absolutely not. And when we talk to our friends at some of those organizations, they say, look, all we want to do is have volume. The last thing we want to do is anger any hospital because they may not contract with us again. And then the question back to them is, so you're okay with that? You're okay with knowingly sending patients to really bad hospitals? And the answer is yes, that's the corporate stance. We're okay with it. So there's a lot of groups in healthcare, hospitals, insurance companies that don't want to see this and don't want to fund this, by the way. And so we've got to go work with the employers. If we can have big employers in every city stand up and do this, if we can have some of the progressive brokers stand up and make a difference, there's a path for these studies to be at no cost to anyone, but we've got to have some healthcare heroes that stand up. And so reach out to us. If you're listening to this and you're passionate about it, anybody in any community can make a big difference by creating a push in your community for some of the large employers to explore this. And when they explore it, they'll do it, and then the study will happen. And
then the incentives for hospitals to be different appear.
Yep.
That's really what we are looking to do, is improve the quality of hospital care for patients.
Well, and I mean, this just speaks to our quadruple aim, and probably a natural segue, right? Patient experience, quality care, lower cost, provider wellness. That all, and then the majority win. The majority win in that scenario. This was, I gotta say, this was an inspiring, illuminating, fun conversation with the two of you, and I hope and I really think it'll happen. Hopefully that you'll get some additional traction with this type of exposure. Why don't we do this? Let's do maybe a fun Ripple challenge question to sort of wrap it up, and then after you each have a chance to answer that, maybe one final imparting thought, and then definitely include your website and where people can contact you. That stuff will be in the show notes as well for the listener. So we'll start with you, Taylor. Tea or coffee?
Oh, see, you just ask a guy whose religion prohibits both. And so I'm a member of the Church of Jesus Christ of Latter-day Saints, known as Mormons, and so we don't drink. It's a health code piece. We don't drink tea or coffee, but I'm going to have to go off of smells. So if you're okay with that, I actually think I quite like coffee if I wasn't born into the family that I was and didn't follow that health code. So,
what are the odds I asked you that question? I had no idea that was your affiliation. Oh my god!
I told you couldn't flap me. So keep going.
Yeah, and you just rolled with it. That was.
Let's
beautiful.
talk about my sex life. I mean, let's just go all the way. I think.
Oh my gosh! That actually came up in a different episode. I'll tell you which one offline. Not from me. Linda, how about you? Tea or coffee?
I'm a member of the Church of Coffee.
Okay. It's interesting. I am also of that religion, I suppose. And although I've been drinking a little bit more tea lately, not hot tea, but I'm in Texas, so iced tea in the summertime is a thing.
Okay.
I don't do sweetened tea, but I have to tell you, we have a really fancy, super automatic Italian coffee machine that makes the most amazing cappuccinos.
That sounds, you've got me wanting that right now. Taylor, you were going to say something there, I believe.
Well, we do herbal teas, so we just don't do green teas, right?
Oh, okay.
It's part of the health code. So I do love a good herbal tea, and I quite enjoy those in the winter. So
that's fantastic. Yeah. Well, how about we give you each an opportunity for maybe one imparting final thought, and definitely include how people can get a hold of you, social media platforms, that thing. Linda, if you'd like to go first, go ahead.
Sure. If there are any nurses listening to this, I would ask you to get in touch with me. We'd love to talk to you about getting some research started in your community and letting you lead the charge to really start to talk about what's happening in your hospital. If there are things you want to talk about, follow me on LinkedIn. Really easy to find. He'll have the link to that. And then follow us on social media. Care Luminate has an Instagram presence that currently is focused on engaging with nurses. We'd love to see you follow us there.
And Taylor, I'd offer the same to you if you have any final parting thoughts.
I would echo the same thing as Linda, which is we need communities to act like communities to help make these studies happen. It's the only way it's going to happen. The good news is it's happening, but you have an opportunity. Everybody listening to this podcast has an opportunity to be a part of fixing healthcare. If you're listening to this podcast, it's likely because you're bothered that healthcare is broken. And it's the business of healthcare that's broken. It's not that we don't have clinicians and nurses that know how to give amazing care. It's that the business of healthcare is broken. This is a chance to fix healthcare. If you listen to this and you don't join in with us to come help fix healthcare, then it's like whining about politics but not voting. Or just add in your metaphor. Then all you are being is an armchair quarterback. You're not actually being part of the solution. This is a way to help fix a huge part of what's wrong with healthcare. Please come and join us. Please make pushes in your community for large employers to pay attention and to come make a difference here with healthcare. We can do this, and we will do this.
This is awesome, actually. And half the time I forget to talk about the book that I co-authored with the patient, which is totally ridiculous that I don't do that in half the podcast. But But it's right. It goes very much in line with what Taylor just said. The goal of Ripple of Change is to inspire and empower everybody to play their part to improve the mess that exists in healthcare right now. And so obviously, the book's on all over the place. Our website is ourquadrupleaim.com. And I'll leave you all with my usual parting words. What positive ripple of change will you create today?
Grab your copy today. Ripple of Change is available in hard, soft, and ebook formats. More information at www.ourquadrupleaim.com. Thanks for listening, and let's turn ripples into waves of lasting change. Stay tuned to this podcast as we search for examples of our quadruple aim.